Good evening, ladies and gentlemen. Today I'll be presenting a case presentation titled Popping Out of Sclera. So an 18-year-old boy presented to the Oftal OPD with complaints of redness in the right eye associated with excruciating pain and diminution of vision. Vision in the right eye was 618, IOP on GAT was 16 mm Hg, sclera was congested, and anterior segment examination was within normal limit, and the anterior vitreous face showed presence of cells. Vision in the left eye was 6.6, intraocular pressure on GAT was 15 mm Hg, and other examination was within normal limit. Here's a slit lamp picture which shows diffuse congestion and associated with pain, so we suspected a diagnosis of scleritis. On dilated fundus examination, we can see presence of disc edema, and in the inferotemporal quadrant, a black homogeneous mass was present in the inferotemporal quadrant. So a presumptive diagnosis of a ciliary body melanoma was made, and the patient was advised further investigations. On ultra-wide field angiography, we can see presence of disc edema and leakage of fluid from the capillaries. In the inferotemporal quadrant, we can see a hyper reflective mass which shows no leakage. So a diagnosis of ciliary body melanoma was ruled out, and the B scan shows the presence of a cyst with a central scolex, leading us to a diagnosis of neurocystic sarcosis. Further, we did an MRI which shows presence of the neurocystic sarcosis in the region of the ciliary body. So we made a diagnosis of ciliary body neurocystic sarcosis. Now, how to manage this case? Surgical management or medical management? We went ahead with medical management and started the patient on tab albendazole 400 mg BD and systemic as well as topical steroids and hometropin eye drops. 2 days later, we saw that the cyst had migrated from the ciliary body into the subconjunctival space and was popping out of the sclera. Now, 2 weeks later, we see that this cyst has lodged itself in the subconjunctival space, and at this point of time is when we decided to do a surgical excision of the cyst. After post-excision, the redness and pain of the patient had resolved, and the popping of sclera had also resolved. So it was a changing diagnosis. There was a management dilemma. Commonly, the neurocystic sarcosis is seen in the vitreous cavity or in the subconjunctival space. It's rarely seen in the ciliary body. All is well when the patient is well. Here is a video showing the excision of this cyst.
Any questions? Any questions, Amit? You can ask any.
So, normally in patient lucky, we don't give albendazole for intraocular investigation. The patient was lucky that the patient didn't have. So, how do you say that was histopathology done of the cyst?
No, sir, histopathology was not done of the cyst.
So, we need to prove it cystic sarcosis. We need to do a histopathology of the cyst whenever you remove it. And if it ruptured through the sclera, it's a rare report, you should report it, but always a biopsy needs to be done of the cyst. So, what should you expect? And albendazole we normally don't give. Because it can lose the eye with the
lose the eye. Cyst can die and cause the inflammatory reaction.
Thank you. With this, we end this session and we invite judges for the next.